Good morning from Campbell, Pennsylvania. I'm Raj Dave. Welcome everyone to Coffee, Cases, and Controversies, our monthly event. It's a great privilege to have two distinguished guests today, Dr. Allen Jeremias, who is the Associate Director of the Cath Lab at St. Francis Hospital in Roslyn, New York. He's also Director of Interventional Cardiology Research at Cardiovascular Research Foundation. His work in coronary physiology is well known. He's been a principal investigator for the defined PCI, defined GPS, fusion, and other OCT-based trials. He's going to be our presenter today and show some very interesting stuff. I also have Javier Escaned, who doesn't really require any introduction. He's well known in the field of interventional cardiology. He's head of interventional cardiology and associate professor at Hospital Clínico in San Carlos in Madrid. He's been associated with C3 for many years. He's been part of multiple different studies, including principal investigator of Syntax 2 as well as defined flare trials. He's also written a textbook on coronary stenosis imaging, structure, and physiology. So he's going to help us co-moderate along with Dr. Göran Olivecrona, who is also professor of medicine at Lund, Sweden, a prolific CTO interventionalist, and my course co-director of the C3 meeting. So without further ado, we have a short 1 hour. I'm going to turn it over to Dr. Allen Jeremias, who's going to talk about a very interesting topic, which we come across a lot in our lab and across the world, that lots of patients come with a chest pain, normal coronary arteries, and how do we evaluate these patients? What do we do about them? Dr. Jeremias.
Thanks, Raj. Appreciate being part of this conference, and congratulations to your success. I know a lot of people are following this, so I'm excited to be part of it today, and especially I think with a very interesting topic, which is microvascular disease. I think this is something that has been around for a long, long time, but maybe testing wasn't optimal, and I think now we have newer tools to do these kinds of measurements. And there's really a renewed interest in the entire field, which obviously is exciting to see. And we're going to be discussing today. So my plan is the following, if that's okay with you. I want to keep this very, very informal. I don't really have a lot of teaching slides. We're just going to go through cases, and then maybe we have discussion after each case so we can get everybody's opinion.
That's great. That's great.
So let me see if I can share my screen. Can you guys see that?
Yep, we do.
All right, very good. So we talked about the topic. These are my disclosures. So I want to spend a couple of minutes just to discuss the mechanics, if you will, the mechanics of doing the actual measurement. This is a picture of the software itself that is used for this. It's kind of an add-on software. The wire is the standard pressure wire that's made by Abbott now. As many of you guys know, it not only has a pressure sensor, but also a temperature sensor. And so the way we make the measurements with that specific wire is by thermodilution, very similar to what we would do in a Swan-Ganz catheter by injecting basically room temperature saline. And so that's what you're seeing here in this screen. So I'm going to walk you through this. The way the measurement is done is the wires advanced typically into the, I would say, distal third of the coronary, very, very similar to an FFR measurement. And my standard is to do resting indices in the beginning. A PDPA obviously comes naturally. The Abbott version of the IFR resting index is called RFR. So that kind of comes for free, if you will, baked into the software. And after that's obtained, we're going to do the first measurements of the resting flow. And that's displayed on the left in the screen here. Actually in blue. And so these are the thermodilution curves. And basically what is measured is the transit time, if you will, of the room temperature saline, which of course is colder than blood. We're injecting, which is very important, with a 3 cc syringe, so not a big syringe. So it's a small bolus, relatively rapidly injected into the coronary. And then again, the transit time is measured, and that's basically what we see here in these 3 blue curves. And the time, if you will, is 0.88, 0.91, and 1. So they're relatively close. I always look at the actual time when I do the measurements to make sure that they kind of are, close to each other. There's no outlier. If there is an outlier, the software allows you to repeat the measurement for that one measurement that didn't quite work. And then we get an average of the 3 measurements, which in this case is 0.93. At that point, we start IV adenosine. And in this case, we have to use IV because we need a little bit longer hyperemia than we would be able to achieve with a simple intracoronary bolus. I usually wait about 1.5 minutes, 2 minutes to make sure I have full hyperemia. And then simply the 3 measurements are repeated. And now, as you see, the curves are shifted to the left, indicating that the transit time is faster, as you would expect, with increasing flow given the adenosine. Again, the 3 measurements are made, and then we have an average of the 3. And then it's a very, very simple calculation. Coronary flow reserve is basically calculated as the resting flow over the hyperemic flow. So we just basically divide these 2 numbers, and we get a CFR in this case of 5, which of course is normal. In most clinical trials, a CFR of 2 or greater was considered to be normal, although this is typically in a population that has some underlying cardiac risk factors at the minimum. In older population, I think if you would do this in younger people, 3, 4, 5 is probably more normal. But for clinical purposes, in a cardiac population, 2 is considered normal. So that's the first measurement that we do, and I hope I was able to kind of convey, it's a relatively straightforward measurement. Honestly, this whole thing takes maybe 5 minutes or less to do both the resting measurements as well as the hyperemic measurements. The second piece of information that we also get is the IMR, or the index of the microcirculatory resistance, and that is calculated also relatively straightforward as the distal pressure as obtained by the pressure wire multiplied by the mean transit time during hyperemia. So in this case, it would be 0.19. And typically what we consider normal is 25 or less, and there's different scenarios where the IMR is used, whether in sometimes there's some studies looking at that in STEMI patients for prognostic indicators. For our purposes today, we're looking at stable angina patients, of course, and an increase in IMR would indicate an increased resistance in the microcirculation. So that's basically how the measurement works. And of course, we also get an FFR with this measurement as well. And so we really have a very, very comprehensive assessment of the microcirculation by having a set of resting measurements, a set of hyperemic measurements, all of which are pretty nicely displayed on this screen.
Allen, may I ask you one technical question? Before you inject saline, you always have some blood in the guide, or some contrast in the line if you're using a cyst or something like that. Does that all should be flushed out before you inject the saline for doing thermodilution?
Yeah, I think that's a great question, especially if you have contrast in the line or in the catheter. Contrast in itself is a hyperemic agent and would create some degree of hyperemia, even though not as much as adenosine, but some degree of hyperemia. Obviously, that's a problem if you want to have rest measurements. So you have to make sure that all the lines are cleared and flushed before you start doing the injections. Any other comments?
After 3 cc injection, do you follow that with like a 5 cc flush or anything like that, or you just do 3 cc because you're going to end up in the guide with a 3 cc, right?
Well, not necessarily, right? Because whatever's in the guide is going to be pushed in. As I said, the injection itself is a quick injection, and what you're looking for is this kind of, the transit time, in terms of the pressure difference, if you will. And so you don't have to flush. It's basically just a 3 cc bolus, quick injection, and
you get the curve.
It literally takes, I don't know, 5 seconds or less to get the curve and get the number, and then you move to the next.
And I assume that this is obviously all computerizedly calculated and shows up on the screen.
The screen will prompt you. So every step has a prompt. So it will tell you inject, right? And then you can accept or decline the injection afterwards, depending on whether you feel it was a good sample or not.
Great. Fantastic.
Javier, do you have any comments in terms of technical aspects?
Yeah, I see some comments from the colleagues that are attending. One is Lalita Sanders. She's asking if this is a conventional FFR wire. And well, this is an FFR wire that is fitted with a thermistor. Is the pressure wire X by Abbott. You could use also Doppler. That's a different approach. But what we are seeing now is something that you obtain with a wire that is fitted with a pressure and a temperature sensor. And also there is another colleague, Allen, the City Blankship, who was asking how long do you want to flush the contrast out of your guiding catheter? Perhaps you can answer that.
Yeah, so if there is contrast in the guiding catheter, I mean, my preference would be actually to suck it back instead of injecting it, because I'm always stingy with contrast, so I like to not inject it if I can avoid it. But if you do inject it, it will cause hyperemia for about 30 seconds to a minute. So if you inject it, you probably have to wait for about a minute or so to be sure you have resting conditions before you start doing your resting measurements. One other point to Javier's comment about the wire itself, this is not a different wire than you would use for FFR. It's the same wire. The only issue is that for whatever reason, Abbott before has not activated to allow us to actually use the temperature sensor on the wire. It always has been equipped with the pressure and sensors and temperature sensor. So it's nothing new. It is only that for whatever reason before the software wasn't really activating the temperature sensor, and now this add-on software allows us to do that.
Alan, there is a question from Dr. Rob from Emory. Is this a different setup from combo map? I'm not familiar with what a combo map even is.
Combo map is the Doppler wire, so it's a different technology, right? So the Doppler wire is a little bit older technology. It is not a temperature probe, obviously, but it's a Doppler probe at the tip of the wire. And that goes along with the combo map, and you can do basically the same measurements, right, with a Doppler-based system as well. And there's advantages and disadvantages to both, which we can maybe discuss later. Okay,
great. Well, let's keep going.
All right, so why don't we go into the cases and just these are all cases from Cormica. And I appreciate the investigator team, Dr. Siddiq and Dr. Berry, sharing these patient cases with me, which I think are very, very instructive to go over. We picked 3 of these case series that we're going to be discussing today. The first one is a 46-year-old female with a 6-year history of exertional chest pain, a number of other medical problems that are not relevant to this topic. She had an exercise stress test. She was only able to exercise for about 3 minutes, stopped due to fatigue, without any significant chest pain or EKG changes. A coronary CTA showed normal coronary arteries. So she was referred for cardiac catheterization to do microvascular testing. This is the angiogram. As you can appreciate, basically normal coronary arteries. Nice LAD, and the RCA also normal. All right, so it's a little bit out of sequence. The first part of the testing is the microvascular testing, which in the slide sequence comes up later. because I had the angiograms first. But basically at this point, one would, do the testing we just talked about, which is the first part, resting, adenosine, and then after that, do an acetylcholine challenge. And as you see, there is increasing doses of acetylcholine administered. So nothing really happens on the left on the angiogram with the lowest dose of acetylcholine. And then at a higher dose, maybe there is a little bit. Let's see if I can play this. You can appreciate that there is a little bit of spasm, right?
Yeah.
Yeah.
Yeah, it's spasming now.
And then this is the bolus, which is very, very severe spasm of the mid-LAD, as you can appreciate. And this goes along with significant ST changes, as you can imagine, in the cath lab. And that's completely resolved with IC nitroglycerin. And when we're looking at the, this is the testing itself. When we're looking at the first part of the test, if you will, the PDPA was 0.95, FFR 0.91. That's always the case, even in the setting of basically normal coronaries, just because of some pressure loss due to the hyperemia. CFR, as you see, is normal. If anything, high normal 5, IMR very low at 12. So the microvascular testing, if you will, came back perfectly normal. The acetylcholine provocation test indicated that there was severe vasospasm with chest pain and, as you see, EKG changes. And so in this case, the diagnosis is vasospastic angina, and the medications that were changed was to add a calcium channel blocker and nitroglycerin as required.
Javier, do you have any comments about the sequence of the testing and how would you interpret it? And, one of the questions that I have for both of you guys is that can we make the acetylcholine test a little bit more simplified? Looks like there's 5 different injections of different concentrations. Maybe, can we just do like a 2? Yeah.
Yeah, so it's well, first, acetylcholine testing is a very safe technique, but it has to be approached in a step fashion. So certainly our experience, and we've been doing this for a long time, is typically we use 4 doses, 2 milligrams, 20 milligrams, 100 and 200, which are injected by hand injection over 30 seconds, roughly through the guiding catheter. So it's very simple, always in the left coronary artery. If you want to do it in right coronary artery, it's slightly different. Now, I will certainly discourage trying to rush to go to higher doses for 2 reasons. First, because the information you get with the lower doses is information that refers to the behavior of stimulating the endothelium. While when you go to the 2 higher doses, you are getting information that refers to stimulating the smooth muscle cell. So the information that you obtain from the test is telling you if what you have is predominant endothelial dysfunction or predominant smooth muscle cell hyperreactivity. The second one, and this is perhaps even more important from a safety perspective, it is always unpredictable to know when you are going to have a very important reaction in terms of spasm. So if you don't go stepwise, you have the risk of having a sudden spasm with your first injection if you rush to try to go to the 200 microgram dose. And certainly that's something that is not recommended. Also, you have to, in some occasions, you will not reach the 200 dose because you see that you induce severe bradycardia. And even if you insist too much, you could even trigger some episodes of atrial fibrillation. In about 5% of the cases, this may happen. So there is no rush. If you want to really embark into acetylcholine, and you should do, because it's the only technique that allows exploring endothelium smooth muscle cell reactivity in a single test, you should follow the rules. It's very simple. It won't take you much.
And maybe I can, Raj, maybe I can comment real quick on the injection itself. So I think the more traditional way of doing it, which is a little bit complicated in all honesty, was to have a microcatheter, typically in the LAD, which is where you do the testing. And so the infusion would be basically only into the LAD, and it's connected to an infusion pump, which makes it very, very challenging and very complicated, to be honest with you, to be able to, administer these very, very small doses also over time, right? The injection is not a bolus injection. It's a more, it's a longer injection. I think the newer modification is basically what Javier was pointing out, that we now do it, just to simplify matters, as a hand injection over maybe 30 seconds. The downside, if you will, of that strategy is that you're injecting into the guide. And so if you have, let's say, severe vasospasm, you could have, very, very significant vasospasm of the entire left coronary tree, as opposed to just the LAD, which might be, more difficult to manage. I don't know, Javier, how many times have you seen somebody having severe spasm, of all the vessels when you're injecting in the left main?
Well, fortunately, we never had the complication. I mean, we've seen severe spasm, but it always reacted to injection of nitroglycerin, and of course, we did not delay in this situation, giving nitroglycerin. So but what is very important is that if you proceed stepwise, 2 micrograms, 20 micrograms, 100 micrograms, 200 micrograms, you get a much better appreciation. And sometimes you don't need to reach to the higher dose. So that's the reason, because I insist, from a safety perspective, it's very important to.
Yeah, makes sense.
Can you put a microcatheter in the proximal LAD and inject through the microcatheter? And then you are more selective, but not through the guide necessarily, and may not expose left main in a circ.
Well, typically the problem is more the opposite. Sometimes what is the problem is that you are not properly engaging the left main. So typically we do it from the radial approach, and sometimes there is no small movement. So it is more, perhaps from my perspective, more important to make sure that when you are making the injection of acetylcholine, you are engaging the left main. That's probably more important.
I see. Allen, so are you also doing the newer way of doing it, 220, 100, and 200 is what I heard. Javier, is that true? Yeah.
Yeah, I'm kind of, it's not easy, to be honest with you, in the US to do this. As you know, in the, this is the formulation we have is eye drops. So, to convince your pharmacy to allow you to inject it in a coronary from a formulation that comes as eye drops is a little bit tricky. So, in all honesty, there's a few hurdles to overcome before you go to acetylcholine testing. So my recommendation for people who start would be to start with the basics, which is the first part of the test, and then maybe add on the acetylcholine testing, later.
So with this case, Alan, I think that there are a few additional things we can comment and share with the colleagues. It's a very interesting case. And if you go back to the angiogram, what you can see is something very characteristic that several groups have found. Now it is already on paper. And is that before you start the acetylcholine testing, the place where this lady is going to develop a spasm is an area that is intramyocardial. You can see that there is even at the beginning the impression that you have a myocardial bridge. Now there's recently there was an excellent paper from the Stanford group with Jennifer Tremmel as senior author, reporting on the physiology of myocardial bridges. And what we have learned with acetylcholine testing is that actually many myocardial bridges, many intramyocardial segments actually do have either endothelial dysfunction or smooth muscle cell hyperreactivity, very much like this. So it came to us, it's quite frequent when we start doing some acetylcholine testing and we see that there is an intramyocardial bridge. In many occasions, we guess that we are going to see something abnormal at that level, and it is true. And it's something new, because in the past we thought that those myocardial bridges that were generating ischemia was due because of compression of the lumen, and a flow limiting effect, if you wish, during enhanced inotropism, etc. But now we understand that some of these patients with myocardial bridges, actually what they develop is a spasm. So it's a very interesting case.
Fantastic. Alan, should we go to the next case?
Okay. All right, so the next case is a 42-year-old female with a 2-year history of angina. And as you see, medical history, anxiety, depression, smoker, obesity, migraine, headache. I don't know if that's the typical presentation, but I think it's not uncommon for sure. She was exercised. She was able to exercise for 6.5 minutes, stopped due to dyspnea and fatigue. And she also had some chest discomfort, but no significant EKG changes. She also had a coronary CTA, which demonstrated normal coronary arteries. And this is the angiogram confirming the CTA finding of normal coronary arteries. I guess you can make the same comment here that Javier made before, that there might be a little bit of a bridge in this mid-LAD. At least it looks like it's intramyocardium for some time. I'm not sure why it doesn't fully run. And the RCA is normal as well.
There may be, but it's hard to tell, huh?
Hard to tell.
The bridge in the LAD, yeah.
Let's see if we can see here better. Yeah, there's
Yeah,
a little,
maybe,
at least there is a hinge point,
tiny,
right?
yeah.
You can see a hinge point.
Yeah.
All right, so far the low dose acetylcholine looks pretty much like the baseline. This is the higher dose. And so what's going on here?
Mm-hmm.
The flow is slow.
Right, slow flow. But the vessel itself looks the same, right?
Yeah.
Yeah, not too bad.
Not too bad. So there's no significant epicardial spasm, but you can appreciate the slow flow. And then here's the bolus. So that's yeah.
Totally obliterated.
All right. That's where I feel like, well, when you inject this in the guide and you have this in your entire left coronary system, maybe that's not optimal. The good news is that as Javier pointed out, most patients respond very well to the nitroglycerin, and you see basically the flow is restored completely to normal. Let me play both from this to this with the IC nitro.
So in the Cormica trial, did they inject acetylcholine with a microcatheter, or did they do it through the guide?
I think they did it to the guide as well.
I see. And
so this is the testing, before we injected the acetylcholine. IMR was 24, which is kind of borderline. CFR is 1.7, which is below 2, so on the low side. And we saw the slow flow in the LAD with the injection of acetylcholine, especially at the higher dose, again with pretty significant EKG changes. So the diagnosis here is microvascular angina or microvascular spasm, right? So as opposed to the first case, which we discussed, which had an epicardial spasm, in this case, there is significant microvascular angina, and also reduced or some impairment of the microcirculation, even without acetylcholine, right? With the CFR being 1.7, IMR being borderline. So there is significant microvascular dysfunction in this patient, and she was changed to verapamil and a statin, and at 4 months had a pretty significant improvement in her Seattle angina questionnaire score from 55 to 72. How often do you see these type of cases, Javier?
Oh, it's a very typical pattern, of course, of vasomotor disorder. And in this particular lady, you could see that the slow flow started happening when you were in the endothelium-dependent doses, low doses of acetylcholine. So it suggests, of course, that what you're having is that the arterioles are developing a spasm. And I'm sure that, with the EKG change, there will be EKG changes and chest pain. They're typically very sort of clear, and the patient refers immediately similar pain to the pain that motivated the study, etc. So I think it's obviously one of these situations that is so clarifying for the physician and the patient, and it's something that we know that is there, endothelial dysfunction as part of, many cardiovascular risk factors, atherosclerosis, etc. And it's great to see that in this particular patient, with verapamil and statins, the patient improves so much.
Now let me.
We always tell them also to have short-acting nitrates to start controlling the symptoms, the occasional symptoms, not as a routine treatment, but it's something that may reassure the patient that if he or she has an attack of chest pain, can control it.
Would it be necessary? So in this case, I think it's pretty clear what's going on, right? Where you have starting the beginning of slow flow at the higher dose. Is it necessary, in your opinion, in this case, to go to the bolus and have, this amount of no reflow?
Not really.
Not really, right? Because you already made the diagnosis at the lower dose, and it's probably safer for the patient to avoid, giving the bolus.
Not really. If you see that a clear modification of TIMI flow, great. Like in this case, by this time the patient will have already chest pain. You will have EKG changes. You have already a positive response. So there is no need.
That's a great suggestion, that we don't have to do this. If we already made the diagnosis at a low dose, don't need to go to the full bolus dose.
For research purposes, I think it's important to follow the full protocol. But if you do this in the clinical setting, you want to do it as safely as possible for the patient.
I mean, you should not panic, but there is certainly no need to go for it. It's again, for the colleagues, remember that the effect of acetylcholine disappears very quickly. So when you see, a typical situation that you see AV block, or you have to not panic. Remember that just it will be a matter of seconds, and it will be recovering very much, But you have, but once that you have clear positiveness of the test, there is no need to go to the higher dose.
There is a question from Dr. Sundar from audience that so both endothelial dysfunction determined by lower doses and smooth muscle hyperreactivity by higher doses of acetylcholine can be treated with a calcium channel blocker.
Well, yes. I mean, that's what we know. We know, of course, more about epicardial vessels. So to put it in a nutshell, vasospastic angina or Prince-Metal angina is predominantly a problem of smooth muscle cell hyperreactivity. The endothelial dysfunction plays a lesser role in the development of these, large vessel focal spasms. On the contrary, endothelial dysfunction, like in this lady, plays a very important role in generating ischemia at an arteriolar level. Is when you are really seeing this. And it's a paradox because actually it is what this is telling you is that when this lady exercises and the oxygen consumption of the heart goes up, paradoxically, the microcirculation is cutting down blood supply. So it's a big trouble what happens in these patients, because these are the arterioles that are sensitive to flow, the ones that go into a spasm. So in other words, although the mechanism is different, the way of controlling the problem is the same. Tackle the smooth muscle cell, because the smooth muscle cell is going to be the one that is going to cause the spasm at the epicardial or arteriolar level.
One question I have for Allen and Javier is, do you always run through the whole protocol all the way up to acetylcholine, even if you have pathology that you find at the CFR and the IMR measurements?
Well, we do, yeah.
I think my feeling is, look, if you have made a diagnosis at whatever point, I don't think you have to run through all the, all the tests, all the bolus, especially not the bolus. If you have a diagnosis, like in this case, I think the diagnosis is pretty clear. You can maybe go to one higher dose if you want, before the bolus, but you don't need to create this type of, no reflow necessarily once you have established the diagnosis.
Yeah, but I thought that the comment of Göran was saying, well, imagine that you perform coronary flow reserve and microcirculatory resistance. You find them abnormal, stop there. Don't go for acetylcholine testing. And personally, I think that you should not. You should try to explore both pathways of dysfunction: endothelial-dependent acetylcholine, endothelial-independent adenosine, because you may have overlap of pathologies. You may have someone who has a problem of a structural remodeling of the microcirculation and vasomotor disorders. And actually, the information we have, the evidence we have, is that actually those are the patients at a higher risk. So it's I think that it's important to count with this information, not only for knowing which is the best treatment or understanding why a particular treatment is not working, but also to stratify risk for patients.
And this would be actually the case example where you have both disorders at the same time, with having an increased IMR and a decreased coronary flow reserve, and also an abnormal acetylcholine provocation testing.
Yeah.
So we assume that the patient needs to be anticoagulated during this testing, correct? They should just get a standard dose of heparin?
Yes.
Yeah.
Great.
Yeah, you
Okay.
have that wired down. I mean, I would say the whole testing protocol is maybe 20 minutes, 25 minutes or so. So you have a wire down the coronary for that time. So you definitely need to do anticoagulation.
Absolutely. It's a very safe test, but you have to play it safe.
Yeah.
So no point in trying to give less heparin than you will give in a PCI or whatever.
Great. How about the next case?
All right, so maybe just in the interest of time, we're going to skip the next, and we're going to go to the last case, which is patient 4. This is a 51-year-old female with a 9 months history of exertional chest pain relating to the jaw, with really no significant medical history at all. She was able to exercise to a little over 6 minutes, had chest pain during exercise, but no significant changes on the EKG. And she had some plaquing on a coronary CTA of the proximal LAD, so there might be a combination of risk in this particular patient. This is the baseline angiogram. Certainly based on the angiogram, it doesn't appear that there is any significant obstructive CAD. But as you guys know, the CAT scan actually is very, very accurate, I think, in determining, any kind of plaque buildup that frankly we would miss based on the angiogram due to some positive remodeling in most cases. So, I mean, in this case, if I did this angiogram, I would call it normal, but we know that this patient has some degree of plaque buildup and underlying CAD. All right, so this is the low-dose acetylcholine bolus. Nothing changed. This is an increase in dose. Still looks fine. And then again, a little bit of slow flow here with the higher dose. Now, the normal response, I think Javier mentioned that, to especially the low-dose acetylcholine, because it does look at the endothelial function, if you will, is a healthy response in the absence of any atherosclerosis would be some degree of vasodilation.
Exactly.
And then this is the bolus. Actually looks okay with a bolus, no significant impairment of flow, and there's no significant vasospasm. And so I would say in this case, just based on the angiogram alone, the acetylcholine testing was negative. And then this is the microvascular testing, what the investigators found that in this patient, IMR was pretty significantly elevated at 41. Flow reserve was decreased at 1.6. And so the diagnosis in this case is basically microvascular dysfunction with preserved, I guess, acetylcholine testing.
Didn't you thought that I thought one of the angiograms with acetylcholine had slow flow?
Yeah, it looked like it in one of the angiograms, I agree. But then, you know, in this one here.
Yeah, I think this one, yeah.
Yeah. But having said that, when you give a bolus after that and it looks perfectly okay, then yeah, I would say overall it's probably negative.
Yeah. But the diagnosis is still microvascular dysfunction anyway.
It's microvascular, well, but not microvascular spasm, right? So the distinction is microvascular spasm if you have slow flow based on the acetylcholine versus microvascular dysfunction with an increased IMR and a decreased coronary flow reserve. This patient, interestingly, actually was in the control group, so no medication changes were done, and the patient continued having symptoms 12 months out.
So in this patient, basically what you can see is that the dynamicity of the coronary microcirculation of arterioles that will be increasing flow in response to adenosine is blunted. So there is no ability to vary or to modulate flow in this microcirculation. That's what coronary flow reserve is telling you. And what IMR is telling you, resistance, which is the inverse of conductance, is telling you that the network is, has an impaired conductance. So either because the arterioles are thickened and narrow, or because you have loss of capillaries, the resistance of this network is increased. So together, the interpretation is that this lady has a structural remodeling of the microcirculation. It is not a dynamic dysregulatory problem like in the vasomotor tones, the vasomotor disorders we saw before. In this case, you have something that is fixed. So therefore, at a difference with the other patients in whom you could tackle the smooth muscle cell, and avoid the spasm, here you cannot do anything at this point to change the microcirculation because it's structurally impaired. So what you can do is to reduce the need of oxygen by the myocardium. Is the way of helping the patient. While, of course, you try to look for any other cardiovascular risk factor or whatever that accounts for this remodeling of the microcirculation, hypertension, for example, and you try to correct that.
So beta blocker would be the best therapy here, or what would you suggest?
I think that's the archetype for the use of beta blockers. Try to avoid limit oxygen consumption. It's the best way of controlling angina in this patient. And at the same time, of course, use statins. Have a look to what concomitant cardiovascular risk factors may be accounting for these changes in the microcirculation and try to correct them.
So, Alan, this is a great segue into, spending last few minutes on talking about therapy. So we talked about different, microcirculatory angina, vasospastic angina, and then obviously non-cardiac patients. So talk between you and Javier, talk a little bit about, after you do this testing, what's your number one choice agent for each of these categories?
Well, let me just make one comment. I guess I don't know if Javier agrees or not, but my interpretation of the Cormica trial was basically this. I think it showed that giving the patient a firm diagnosis actually makes a big difference. I think that's really the bottom line, right? Because these patients often are called crazy. They have a million angiograms, they have a million stress tests. Nobody can ever find a diagnosis. So giving them a firm diagnosis, I think, is very, very important from a psychological standpoint. Where the trial might not be as good, and obviously also, in all fairness, it didn't really look at that, and we need more data, is what do we do for the different entities? Because now we made the diagnosis, which of course is important, but at the same time, we would like to also offer some treatment for the different entities. And so I think that's a little bit of experimenting, frankly, based on the findings. This is what the investigators suggested as a bottom line. So there's basically three buckets based on the findings that you can have. You can have microvascular angina. This is the last case that we talked about, where you have this kind of fixed defect of the microcirculation, and the recommendation, as we discussed, would be beta blockers, statins. Probably statins are good for all of these, lifestyle changes, hypertension control, and so forth. The vasospastic angina, be it in the epicardial or the microcirculation, I think is best addressed with calcium channel blockers, plus minus sublingual nitroglycerin. And then also importantly, don't forget that there is about 35% of patients who have normal microvascular testing. And so in those cases, the diagnosis of non-cardiac chest pain can be established, and maybe other treatments can be offered to the patients.
I think that it's a great summary. I think that to complement it also from said in other words, I think that one of the big lessons of Coromica is that the term microvascular dysfunction is too vague, and that it's much more important to identify the mechanism of dysfunction, what we call endotypes of microvascular dysfunction. If it is, in the case of Coromica, if it is a vasomotor endotype, and Allen has emphasized the importance of calcium channel blockers, also ACE inhibitors, by the way. ACE inhibitors, there's ample evidence that they tend to normalize also endothelial function, and then statins. And the other, that is the structural endotype, which is the one that is reflected by, that requires beta blockers, statins, and changes in lifestyle. And then, but as I think that your comment is very important, Allen. This does not complete the whole picture. We need further information. For example, just to give you an example, if you have someone who has typical angina during the adenosine infusion, for example, and you have otherwise entirely normal, acetylcholine testing and coronary flow reserve resistance, there may be good reasons to understand that these people who have typical chest pain when you give adenosine, what they have is some sort of proprioceptive hyper sensitiveness to adenosine that is causing chest pain, And remember that in the past, there were studies trying to treat these patients with aminophylline or caffeine, which is an antagonist of adenosine. So I'm sure that in the future, we will have more information about how to better use the information obtained in testing for setting treatments, I think.
Dr. Colin Berry, who is going to be the PI for iCoromica trial, another large 1,500 patient cohort trial, which is started OUS, which will also evaluate and track the outcomes on the treatment arms from iCoromica. So we would be looking forward to the results of that. In fact, Dr. Colin Berry will be our guest for our next show on March 6th. So please make sure that you reserve your time to join us. It will be very, very interesting. Great comments. Only a couple minutes left. Lots of learning. A completely new availability of the software now in US, which is making this possible. I think that, I've been hearing a tremendous excitement about having the possibility to be able to make this diagnosis in this very difficult patient population where repeated coronary angiogram and variety of different things have been tried in the past without a tool to do this. I think that this is very exciting. Next chapter in the cardiac cath lab to evaluate for vasospastic and microvascular dysfunction should be very useful. Any final comments as we have a last 5-6 minutes left for the show from Göran, Javier, and Allen?
I think it was a great presentation you held, Allen, and fantastic comments, Javier. I learned a lot. One sort of question is that How many patients do you see in your cath lab that you run through with this? Because I mean, we have tons of patients that have, chest pains and so on. How do you have a structured way of picking out the right patients to bring into the cath lab to go through the whole procedure?
Yeah, thank you. That's a great comment, Göran, because my impression is that this is the type of physiology that interests not only the interventional cardiologists, but interests particularly the clinical cardiologists. Actually, we've been extremely successful. I was telling before starting that the two type of patients that have rocketed over the last 5 years at our institution are TAVI patients and non-obstructive coronary arteries patients. And that's the reason because our clinical cardiologists have understood the enormous value that this information has for them in setting the effective treatment. So, it's I think that we have reached a tipping point and that we are going to see this more and more. And that at the difference with FFR and IFR, that is information for the interventionalists, we are going to have now the request of the clinical cardiologist of having this type of information on non-obstructive causes of angina.
Alan, the way you describe the testing and the time, I would say that, I'd be just inclined to do it right there and then when I get a patient with a normal coronaries and just go ahead and put the wire down. And the only issue would be the acetylcholine. And I think that there was a protocol that was earlier in a couple shows ago, Dr. Firan gave me the mixture that how to do it from the eye drops. And I think one of these shows will bring that information for the audience. But it seems like that once you solve that, it seems fairly easy to do it.
Yeah, I think first of all, to Goran's question, if you look at the data we currently have, I would say about a third of patients come to the cath lab, with chest pain or abnormal stress test and actually have significant epicardial disease, which basically means 2/3 of patients that we cath do not have any critical lesions, right? Now, some of those actually, part of the reason why I like to do the testing is because I would say maybe 5% of patients or so actually will have an abnormal FFR in the setting of, maybe mild to moderate angiographic disease. So we frequently underestimate the disease, especially in the LAD. And when we do physiologic testing, we find that there is significant epicardial stenosis. But having said that, still 60% or so of patients will not have any significant epicardial lesions, yet have angina. Now, I wouldn't recommend to say, well, all of them, 60% should undergo this type of testing. We have to be a little bit more selective than that. But I think based on a good history, we can basically distinguish patients who really have pretty typical symptoms, have had this for some time, as opposed to these more atypical type of chest pain patients. And in those cases, I completely agree with you, Raj, that if you can do it right then and there, as I pointed out, it doesn't really take a long time to do this. And sometimes, in those 5% of cases, FFR is abnormal, you might actually need to do a PCI. So it would make sense to do it ad hoc, especially the first part is very easy. Ideally, if you're equipped with the acetylcholine to add that on, it would certainly help.
Javier, have you thought about doing an IMR testing in other type of patient populations, such as, acute MI or after supersaturated oxygen therapy or something to assess, how good of a PCI result you have achieved?
Absolutely, absolutely. The interest, of course, we've been interested in the microcirculation in many different diseases for a long time. The great achievement of the CORMICA trial is that it identified a very practical endpoint, which is improvement of angina. And it demonstrated clearly that you can improve quality of life and control angina in patients who have, chest pain with based on this type of vascular dysfunction. But we have now to expand this to try to understand if we can modify prognosis. This is something that we still don't know. And I anticipate that there are some groups of patients where this is going to have a huge importance. One of them will be the patients with hypertension, because the response of the microcirculation to hypertension is quite heterogeneous. And we know that some of the patients who developed, hypertensive heart failure in the long term start by having some problems in the microcirculation. And also acute coronary syndromes. We need to improve survival of patients once that we achieve, TIMI3 flow with primary PCI. And we know for the time being that are those who have damage in the microcirculation in the acute setting, the ones who will have a poor prognosis in the long term. For the time being, what we need is to obtain more evidence, more information on whether that information obtained at the time of primary PCI can be followed by specific treatments that may modify prognosis. But I'm positive that we are going to see a lot of research using these tools out of chest pain.
Alan, any thoughts about other use of IMR? Looking at, because there has been some literature about IMR's prognostic implications in STEMI.
Yeah, I think Bill Fearon had actually done a lot of work on that, and he's kind of the thought leaders and pioneers in that arena, if you will, in the setting of acute STEMI. And when you think about it, from a logical standpoint, it makes perfect sense to look at IMR after you were established to establish TIMI3 flow, because the truth is that even though you might get a good angiographic result with putting a stent in the setting of a STEMI, the microcirculation might be, still in jeopardy, if you will. And IMR is actually a very easy way to kind of assess that. And based on Bill Fearon's work, we also know that patients who have significantly elevated IMR in the setting of STEMI have worse prognosis and certainly a larger area at risk based on a MRI post-procedure than those patients who have lower IMRs in the setting of STEMI. And I think it's also important not to do this routinely necessarily, but it's important to understand that this actually is a very, very powerful research tool to assess therapies that potentially might improve microcirculatory function in the setting of STEMI, like the supersaturated oxygen, for example. I think it would be a very, very interesting study to do this IMR before and after to actually see how much effect can we achieve with those kinds of therapies.
Yeah, I also think that, I've also thought about, that maybe could be a tool that can be used to with a device like Impella in patients with shock to see the results of the PCI, because we used to in the old days look at the myocardial blast rate all the time with the Rio Pro trials and the trials with the intracoronary efiximab along the way to determine how good of a job we had done, and also many thrombectomy trials. So this might be another tool in future research in understanding the impact of therapies, as well as some of these tools that we use for these type of cases.
I agree.
Yeah, I mean, in this setting of STEMI, I mean, this is the time we have we have the availability, if we do an IMR, to do something possibly when we have therapies. After that, the show is over after you've done the MRI the next day and you see the microvascular obstruction. So finding out if there is a problem on the microvasculature, you now have the opportunity, if you can find direct therapies, possibly like newer medications or possibly even Impella to reduce some of the distension of the ventricle, for example.
That's great. Well, thank you very much, everyone. Thanks, audience. We had a full house here today, over 700 people watching. So that's phenomenal. I look forward to re-inviting all of you on March 6th for our next show, when we'll have Dr. Colin Berry, who was the PI for the Cormica trial and also the principal investigator for I-Cormica trial, who's going to be our guest on that day. So we'll continue this discussion of this new technology. Thanks to Javier and Alan, both taking a time out of your very busy schedule. And Göran, thank you very much for taking time out of your busy schedule today in Lund, Sweden. So, and I thanks all the audience who's been very patient to be with us. I hope that we have answered all your questions and have a wonderful rest of the weekend. Thank you very much.
Thanks, guys. Bye.
Bye.
Bye-bye.